All right, we're going to see how far we can get during this lecture. I have a house full of kids today, so we'll see how far I can get. But I need to go ahead and get this lecture done and sent out to you guys. So this is the process of normal labor, chapter 6. Labor is, all right, where's my mouse? There we go. Missed a slide. There we go. Labor is the process by which the fetus, the placenta, and the amniotic membranes are expelled from the uterus. That's the actual definition for labor. It's the onset of labor occurs due to a combination of things. Changes in maternal hormones, the stretched uterus, an interaction between the placenta and the fetal pituitary, hypothalamus, and adrenal glands. All right, factors that influence the process of labor. We've got maternal preparation. Is the mom ready? Has she attended any classes? Does she know how to change a diaper? Has she ever been around kids before? Labor support. Does she have a support person? Does she have a significant other, a spouse, someone that's going to be there, family member that's going to be there to help her out? Maternal positioning during labor and delivery. Positioning can make a significant difference in how labor progresses. So you need to make the easiest path for the infant, the least resistance, path of least resistance. Okay. And then procedures encountered by the mother during the labor process, whatever procedures she may receive during the labor process. All of these are going to influence the process of labor. All right. Events prior to the onset of labor. So these things are all going to occur before labor starts. This is lightning. First, there's several things actually, 6 of them. We're going to discuss lightning, nesting, the mucus plug, Braxton Hicks, cervical changes, and rupture membranes, ROM. Okay. The first one, lightning. Lightning is when the presenting part settles into the maternal pelvis. It occurs approximately 2 weeks prior to the onset of labor. The woman has a sense that the baby has dropped. Hopefully it's the head that is the presenting part. The mom usually breathes a little bit easier at this point and eats more at mealtime. However, there's more pressure on her bladder because now the baby, instead of being so high up, has dropped down, puts more pressure on the bladder, but allows more expansion of the diaphragm and the stomach and allows her to breathe easier. She may experience leg cramps and edema of the lower extremities related to increased pressure on the blood vessels by the growing uterus. All right. Other events, the second one is nesting. Nesting is when you get this burst of energy that's experienced by the mom to prepare the home for the new baby. So you'll hear about these people cleaning, preparing multiple meals, preparing the nursery, getting things prepared for the baby. It usually occurs 1 to 2 days prior to the onset of labor. The cause is unknown. But you want to make sure that you warn the mom that if this happens, she does still need to conserve some energy for the work of labor, because sometimes they will feel so energetic, they'll do lots of stuff. And then when it comes time for labor, they are just exhausted because they have cleaned the house up and down. They've done their spring cleaning in the middle of the winter or whenever this occurs for her. Personally, I never experienced nesting. I'm sure my husband wishes I had. But I never did experience nesting. I never had this great burst of energy at all. But a lot of people do. All right, the third thing was mucus plug. So the mucus plug is a protective plug of mucus inside the cervix during pregnancy. And we may lose our mucus plug. It occurs anywhere from 4 weeks to 1 day prior to the onset of labor, the loss of the mucus plug. And it expels as the cervix starts to expand and open up. So as the cervix starts dilating a bit, the mucus plug will be expelled. Fourth, the Braxton Hicks. Braxton Hicks contractions are irregular, painless practice contractions. I hate saying painless because you feel them, you know that they're there, but they're not stop you in your tracks, have to stop and pant through them contractions. So that's really the difference. They're also referred to as false labor contractions. Now, due to what the difference is between these and regular labor contractions is the fact that these are not going to increase in intensity or duration or frequency. So they, in fact, will get less frequent, less intense, They will be more spread apart, not every 5 minutes, coming on to every 3 minutes and getting stronger and stronger. So that's one of the clues to the difference between these contractions, between Braxton Hicks and true contractions. All right, then we've got, this should actually say cervical changes up here at the top, sorry. Cervical changes, that's number 5. So clinical signs for cervical changes, we've got ripening of the cervix, how we're going to do this, effacement and dilatation. So ripening is actual softening of the cervix. Then you've got effacement, which is thinning of the cervix. And then you've got dilatation, which is the opening of the cervix. So be sure that you understand these 3 words, the difference, and what they truly mean, not memorizing what I'm saying to you, but understanding the true meaning between ripening the cervix, effacement of the cervix, and dilatation of the cervix, because there are 3 distinct phases, okay, of cervical changes in preparation to labor. All right, and then we've got effacement, so the thinning or shortening of the cervix. It is recorded, oh wait, hold on. Yeah, these slides, sorry. This is one of those PowerPoints that I meant to do over again, I guess, and never had time to do. So effacement, this is actually just that second phase, or there were 3 things we discussed with cervical changes, so ripening, effacement, and dilatation. So I'm going to talk to you about effacement right now, and then I'm going to talk to you about dilatation a bit. Okay, sorry about that confusion. So just to make sure we're all on the same page, cervical changes was number 5. Of the events prior to the onset of labor, cervical changes, and those consisted of ripening, effacement, and dilatation. And now we're just going to go into more detail on effacement and dilatation. It's still part of cervical changes, okay? So effacement is the thinning or shortening of the cervix. It is recorded as a percentage. They will say you are, 20% effaced, 50% effaced, 100% effaced. A normal cervix is approximately 2 centimeters long, or non-effaced at 0%. When the cervix is completely effaced, it's as thin as a piece of paper or 100% effaced. Okay, so that means it's very thinned out. So we went from 2 centimeters in length, 2 centimeters, I'm not very good with numbers, about 2 centimeters to being as thin as a piece of paper, and that would be 100% effaced. Okay, so where's my thing? Here we go. Here's good pictures here of effacement. So here's before labor, early effacement, complete effacement, and then here's effacement and dilatation. Okay, so dilatation is when the cervix opens to allow the passage of the fetus. It is measured in centimeters, and complete dilatation is 10 centimeters. So when you'll hear people talking about that all the time, 10 centimeters dilated, that is complete dilatation. All right, for a primip, if you'll remember, if you don't remember, go back and look, know what a primip is. Primipara usually experience effacement before dilatation. Now, multipara, effacement and dilatation will occur at the same time. They will often dilate 1 to 2 centimeters before the onset of labor even begins. All right, true versus false labor. Okay, so we've got in here, well, if I can get the mouse to work, progressive dilatation and effacement. These are true labor over here on this side. These are going to be false labor symptoms over here on the other side. Okay, so progressive dilatation and effacement. Over here on false labor, we've got no change in dilatation. Rupture membranes with true labor. The membranes may or may not rupture in false labor. True labor, we've got a bloody show. In false labor, we had the absence of a bloody show. Bloody show, if you don't know, is mucus, pink tinged mucus, basically. Some vaginal discharge. And you can see the rest there for regular contractions, irregular contractions. That was that Braxton Hicks versus true labor contractions. The pain intensifies, contractions getting stronger. Okay, so we talked about that with the Braxton Hicks. Okay, then we've got rupture membranes. This was the final of those pre-labor stages. So spontaneous rupture membranes, I think we talked about this the other day. I put it up on the board. SROM, because most people think ROM is range of motion. For OB, it is rupture membranes. So we've got spontaneous rupture membranes. That is often considered the onset of labor if we have spontaneous rupture membranes. If contractions and cervical change do not occur with the onset of the rupture membranes, labor is often induced due to the risk of infection to the mom and the baby, because now there's no barrier protecting them from getting an infection. If they are, so, as long as they're close to term, we're going to go ahead and deliver. Now, we've had patients, many patients that will rupture very early in the 20-some week range. And at that point, it's a matter of trying to hold off as long as we can. So we're going to be giving antibiotics to the mom, monitoring her. She's probably staying in the hospital, so we can do monitoring. Of course, we're monitoring for infection. So what things are we monitoring for? We're monitoring for temperature, fever, seeing if she gets a fever, if she gets any other symptoms, any kind of vaginal discharge, or any unexpected changes, increase of contractions, things like that. All right, the rupture can be a trickle or a gush of fluid. It depends on how high or how low the leak is of the membranes. So not everybody gets this big, massive gush of fluid. Some people just get a little trickle. And then we've got AROM, which we talked about a little bit, artificial rupture of membranes. That's when the practitioner uses an amni hook. Told you it looks just like a big long stick with a little hook on the end. And they poke a little hole. They basically just snag the membranes and poke a little hole in the amniotic sac that stimulates the maternal hormones to augment labor. All right, the 4 P's of labor. Pelvis, passenger, power, psyche. You need to know them. The pelvis, we're looking at the size and the shape of the pelvis. Can the fetus pass through? The passenger, looking at the fetus. How big is the baby? What position is the baby in? The powers, the effectiveness of the contractions. Is she having strong contractions or very weak contractions? Are they real frequent? Are they very irregular still? And then psyche, the preparation for labor and delivery of the mother. Can also be previous labor experience of the mother. Okay. All right, number 1, the pelvis, or the passageway. The bony pelvis forms the rigid passageway in which the fetus is delivered vaginally. So the shape and dimensions of the woman's pelvis indicates whether or not she will be able to have a vaginal birth. The cervix and vaginal canal are also part of the passageway, made up of soft tissue. Okay, so we've got a pelvic inlet, and we're measuring the transverse diameter and the AP diameter, the anterior posterior diameter. All right, and then we've got our prominence of the bony spines here, the ischial spines. And here's the baby coming through. Okay, so we've got to make sure the baby's going to fit and that the baby is the right way. You see the face is down here on the backbone near the spine. This is the pubic bone. This is the way we want the baby to come out. Sometimes babies come out sunny side up, and face is up here. Back of the head down here on the tailbone. It's very painful. That's unfortunately the type of labor and delivery that I had. And it hurts. It's possible, but it hurts. All right, so it's the shape of the pelvic shape. Is the shape of the pelvic inlet that determines the pelvic type. So there's 4 types of pelvis. We've got the gynecoid, anthropoid, android, and platyploid. Gynecoid is your optimal pelvis for vaginal birth. Your anthropoid is a more elongated pelvis. Your android is a heart-shaped pelvis. And your platypoid is a flat pelvis. All right, gynecoid pelvis. This again is your ideal one for birth, or ideal pelvis for birth. It is the typical female pelvis. Half of the women have a gynecoid pelvis. The rounded shape allows for the infant to negotiate the dimensions of the bony pelvis and the ischial spines here very well. Let's see if I can get my picture over. Okay, then we have the anthropoid, where the dimensions are very elongated. You can see how this is going to be difficult to deliver vaginally. The android is your typical male-shaped pelvis, and it's more heart-shaped. Obviously very difficult to deliver vaginally. And then you've got your platypoid, which is the least common type of pelvis, but you can see that it's very flat, and we've got to fit this round head through this flat pelvis, and that's going to be very difficult. All right, your flared ilium, sacral promontory, the pelvic brim, the symphysis pubis. This is your pubic arch. Okay. So you can see the difference here in your female pelvis and your male pelvis, how it is very much more flat and more heart-shaped. All right, then we've got the passenger. The pelvis was number 1, passenger number 2. Our passenger refers to the baby, the fetal skull, fetal attitude, fetal presentation, fetal position, and fetal station. All right, all of these are going to affect the labor progress. The fetal skull, most important fetal structure in relation to labor and birth. The diameter of the skull must be small enough to allow the head to travel through the bony pelvis. So if we've got a baby with a really large head, this is going to be very difficult. Cartilage between the bones of the fetal skull allow for overlapping during labor. So the fetal skull will actually overlap and then it will come back into alignment. But doing this overlapping allows for a reduction in the size of the fetal head. Right, molding or elongating of the fetal head also allow for accommodation through the birth canal. It's more pronounced in primiparas. They will have much more molding and elongation of the fetal head if it's their first babies. All right, so I'm going to show you some more pictures here. This is the fetal head molding. So you can see how it's elongated, stretched out right here. These are the suture lines, the birth canal, and these sutures will just cross over each other if needed. Okay, you've got your suture lines here. Here's your posterior anterior fontanelle, posterior fontanelle. Your anterior is much larger and diamond shaped. Posterior is smaller and triangular shaped. All right, fetal attitude. The most common and more favorable for vaginal birth is flexion. The fetal attitude is the fetal position, so flexion is the most common and more favorable for a vaginal birth. So if the fetal head is flexed, excuse me, that's what we want. Flexion will present the smallest diameter of the fetal skull through the bony pelvis. It's approximately 9.5 centimeters in presenting size. Remember, how much did our cervix dilate? Our cervix dilates to 10 centimeters. If we have flexion, the head's down, and this part presents first, and it's approximately 9.5 centimeters in presenting size. This is all planned very nicely. Okay. Changes in the fetal attitude, particularly extension of the head, causes the fetus to present a larger diameter of the fetal head to the maternal pelvis, making vaginal birth much more difficult and sometimes actually impossible. Flexion is what we want. Here we've got minimal, we've got a normal, what's the word? Military presentation it's called, where there's no flexion or extension. And we've got some extension here, and then we've got hyperextension. Okay? We want this to be the presenting part. So here's a better picture here. Well flexed fetal attitude, vertex presentation, and then you've got your no flexion or extension, your military presentation. This is your partial extension, your brow presentation. And then you've got your full extension, which is a facial presentation. These babies come out very bruised, as well as these. Faces will be very bruised if they are able to deliver vaginally. All right. So you want the baby to be in a vertex, well-flexed presentation. or attitude, I guess. All right, fetal presentation is determined by the body part of the fetus that is the lowest in the maternal pelvis. So there are 3 main ways the fetus can present itself. We can have cephalic, which is head first, 96% of deliveries, and that's the way we want it. Then we've got breech, which is feet or buttocks first, 3%. And then we have a transverse or shoulder presentation, which only occurs about 1% of the time. Usually now with modern technology and ultrasounds, we're able to detect this before we get into a delivery status where we know that we're not delivering that way. All right, so here is your vertex presentation. This baby is flexed, so that's our attitude. Fetal attitude is flexion. Vertex is the fetal presentation. This is a breech fetal presentation, okay? This is a footling breech or an incomplete breech. This is when you've got your feet down first, and this happens occasionally, and literally feet come out first. It's kind of scary, okay? We've got to get the baby out quickly. So we may also have a complete breech, which is where the buttocks come out first, an incomplete breech. Right here is your incomplete breech. So we've got 1 foot up, 1 foot down. And then we have a frank breech, which is when both feet are straight up, and these babies are, it's kind of funny when they're first born and you try to pull their legs down, they just flop right back up because that's the position that they're used to being in utero. So, this is interesting, but it does happen more often than not. All right, then we've got our shoulder or transverse presentation. So this is when the fetus is in a transverse lie presentation across the belly. So when I was pregnant with the twins, I had 1 breech and 1 transverse, just like this. I think my transverse was up here and breech down here. All right, fetal position is determined by comparing the relationship of the presenting part to the quadrants of the maternal pelvis. So the nurse must first establish the presenting part and then the appropriate reference point. So if the fetus is vertex or cephalic, the fetal position is referenced by the position of the occipital aspect of the fetal head. Right, next, the nurse must determine the side of the maternal pelvis that the presenting part is facing. So for example, if the occipital side of the fetus is facing the mom's right side, or if the occiput is facing the left side, that's how we're going to call it. And lastly, with fetal presentation or fetal position, we have the nurse designating whether the occiput is facing the anterior or the posterior portion of the pelvis, or if it's transverse. All right. For example, if the fetus, let's see if I can move my picture around here. If the fetus is facing the mom's back, he or she is in anterior position. The occiput, the back of the head, is to the anterior pelvis. Okay? The fetus, I've got pictures for you. I've got pictures coming up, so just work with me, and then we're going to see some pictures. All right, if the fetus is facing the mom's front, he or she is in the posterior position. The occiput is to the posterior pelvis of the mother. And if the fetus is facing one side or the other of the mom, he or she is in occiput right or occiput left transverse position, depending on which way he or she is facing. These are fetal positions. You're going to need to know these. I'm sorry, but you are. So make some note cards, make a poster, write all this stuff down, whatever you need to do, because you are going to need to know these fetal presentations or fetal positions. You are also going to need to know fetal presentation as well. But for fetal position, we're going to need to know if we are occiput posterior or occiput anterior. Okay, occiput anterior. Here's the occiput anterior, because this is the front of the maternal pelvis. This is all in position as if the mom were standing in here. The mom were standing here looking at me or you watching this. So her front is to you, her back is to the computer. So this would be the front of the maternal pelvis, and the baby's occiput, the back of the head, is on the mom's posterior side. So this is occiput posterior. We have left occiput posterior, left occiput transverse, left occiput anterior, occiput anterior, right occiput anterior, right occiput transverse, and right occiput posterior. Okay, I know that's confusing. Please take some time, ask me some questions about it, but you really do need to know this. So here it is again. Remember, this is always going to be the anterior pelvis, posterior pelvis back here in the back. Okay, this is a cross section of it. Left occiput posterior, left occiput transverse. Okay, here's all your pictures. So what we would prefer would be which positioning, since we've talked about this a little bit before. What we really, this is what we really want. Right occiput anterior, ROA, or LOA, but we really want OA, occiput anterior, okay? Because remember I told you earlier, if we have occiput posterior, it's much more painful because we have the hard skull of the baby's skull rubbing down the hard bony prominences of the mother's spine. It's much more painful. All right, so LOA or ROA are the most common. If you have OP, occiput posterior, LOP or ROP, this is what we call sunny side up. And when you get your back labor and back pain. All right, anterior versus posterior. Your posterior position, the fetus is facing outward towards the mom's abdomen. So the occiput, the back of the head, is the hardest part of the baby's head, is pushing against mom's lower back and sacrum, causing a lot of back pain for the mother, referred to as back labor. And labor is often prolonged due to the different diameter of the head fitting through the maternal pelvis, because remember, this isn't exactly how it's supposed to be going through the pelvis. The baby may be born with bruising, very, very common, on the forehead, where the softer part of the baby's head has been pushed against the mom's bony pelvis in the front. All right, so here's another good picture for you of anterior versus posterior. So this is the facing backward, head first. This is your normal presentation, and this is your abnormal presentation. When they're facing up, then they'll come out sunny side up. Be sure you understand all those. Ask me questions, please, if you have any questions. Fetal station. Fetal station is the relationship of the presenting part to the ischial spines of the pelvis. When the widest diameter of the presenting part is at the ischial spines, it's referred to as station 0. So you will have a fetal station of +1, +2, 0, -2, -1. Okay, I'm going to show you some pictures here to explain this a little bit better. But I highly recommend making some note cards defining these different things. Fetal presentation, fetal position, fetal station. These are difficult concepts, and you guys are just going to have to know them and understand them. Not just memorize them, but actually understand them and how to differentiate or distinguish what's going on with the baby. Okay? So fetal station, any position above the level of the ischial spines is referred to as a negative station, and any position below the level of the ischial spines is a positive station. So if we have +4 to +5 station, that's crowning and delivery. The fetal head is seen at the vaginal opening. Okay, here, let me show you this picture to explain a little bit easier. So here's 0 station at the ischial spines. If we are up here at -3, the baby's still very high up in the vaginal canal. We're not close to delivery just yet. So as we're checking the cervix and we're measuring, the baby's coming down, we can feel the ischial spines in there, and that's how we use that to determine positioning. So we feel the ischial spines. If we feel the fetal head, fetal scalp right there at the ischial spine, we'll say the baby's at station 0. If we feel the baby down below the ischial spines, 1+, 2+, 3+, okay, 4, 5+, the baby's crowning. Okay? Please be sure that you understand this concept and what that really means as far as delivery, where the baby is, what's happening with the baby, and things like that. All right. Next, we've got powers. The primary force of labor comes from involuntary muscle contractions of the uterus. Labor contractions. They dilate and efface the cervix during the first stage of labor. Oh, I can't move my picture around everywhere. Sorry. The secondary force of labor comes from, we just did this, didn't we? No. Let me go back. Primary force of labor comes from involuntary muscle contractions of the uterus. And secondary force of labor comes from voluntary muscle contractions of the abdomen, and that is maternal pushing correlated with the labor contraction delivering the fetus. Yeah. So powers, uterine contractions, they're composed of 3 phases. I'm going to get all this up here. So this is increment, acme, and decrement. Your IAD. Increment is building of the contraction. This is the longest phase. The contraction strength gains as we go through increment. When we hit acme, we've hit the peak of the contraction. The contraction's reached its strongest point. And decremation is relaxation of the contraction. So contraction of the uterus eases and relaxes, to the uterine resting tone baseline. So when you see contractions on a monitor, you see them going, ooh, okay? I'm going backwards on my screen here. So you see them up and down, up and down. So when we're going up, that's our increment. When we reach the top, we're at acme, and down is our decrement. It's uterine relaxation. Okay, anatomy of a contraction. This is a very good example for you. So this is increment. We're building up. We hit the top, our acme, and then we're relaxing again and down to decrement. Then we have a period of relaxation, and then we start again. Okay. I know this is a lot of material, so please ask me questions, whatever you have questions about, so that I can explain a little bit easier to you, because this stuff, honestly, you're just really going to need to comprehend it instead of memorizing it so you can apply it. Right, contractions start at the top of the uterus and spread throughout the uterus. So they're going to start at the fundus. Remember, the fundus is way up high. They're going to push the fetus downward, which in turn puts pressure on the cervix to thin and efface and dilate the cervix. Okay? Seems very simple. Make sure you understand this concept. So the uterus between contractions is at a nice resting tone. And then you can see the uterus during contractions. Very tight, pushing. That's what it's doing. The uterus is pushing as well as the mother is pushing. Okay? So we have a resting phase. The uterus is down here, relaxing. And then during contraction, it does ball up. It gets very hard and tight during the contraction. All right, documentation of contraction. How are we going to document? We document with frequency, 3 descriptors: frequency, duration, and intensity. Frequency, duration, intensity. Frequency is how often the contraction occurs. We measure frequency by counting from the beginning of one contraction to the beginning of the next contraction. And that's really important. It's not from the beginning of one to the end of one. It's not from the beginning of one to the acme of one. It's from the beginning of one contraction to the beginning of the next contraction. That's how frequent your contractions are happening. It is recorded in minutes. And next we have duration. That's the time frame from the beginning of the contraction to the end of the contraction. So this is how long the contraction lasts. What is the duration of the contraction time? It is measured and recorded in seconds. And then we have intensity. This is the strength of the contraction. So it is determined by palpating the fundus, putting your hands on the fundus at the peak of a contraction. It's documented as mild, moderate, or strong. And it can also be measured accurately by an intrauterine pressure catheter. This is an invasive procedure. It's not used all the time. It is sometimes, but not always. Now, how we determine mild, moderate, strong? We all like to have, what do we determine as a mild, moderate, or strong intensity so that we all kind of have the same baseline? So for a mild contraction, it's going to feel like the tip of your nose. It's a little firm, but still squishy, okay? A moderate contraction is going to feel like your chin, a little bit more firm. And a strong contraction feels like your forehead. It is hard, okay? Then we have our period of relaxation, the interval of resting time between contractions. So during contractions, when the contraction is occurring, there's decreased blood flow throughout the uterine arteries and intravillous spaces, therefore decreasing oxygen flow to the fetus. So that's very important. That's why we can't have what we call hyperstimulation, too many contractions right in a row, right on top of each other. Without any resting tone, the baby is not getting a good oxygen supply. Because with each contraction, we have decreased blood flow to the fetus, therefore decreased oxygenation to the fetus. It's very important for the well-being of mom and baby to have this period of rest. It allows for the vessels to fill with oxygen-rich blood for the uterus and placenta, facilitates rest so that maternal muscles don't become overly fatigued, and gives mom relief from the pain of labor for a few minutes. Right, number 4, the 4 P's of labor into psyche. This is the psychological state of the laboring woman. So the labor process can be enhanced if the woman feels confident in her abilities to cope with the process of labor. She's very unconfident. I can't handle this. I'm so worried about the pain. That's kind of how the whole thing's going to go. So if she finds a way to work through the contractions, feels confident in her abilities to deal with contractions, the labor process will be enhanced. It will, however, be delayed if she's fearful and tense, or if she fights against the pain and against the contractions, tenses up and tightens up with each contraction. We're delaying the labor process. So I don't know if you've ever heard, but it happens sometimes where people will labor for a long time, and then once they may not want to have an epidural or whatever, once they finally get an epidural or some pain medication, the patient, the mother, is actually able to relax enough to allow the body to do its own thing. So because it can be delayed when she is tense and fearful and fighting against the contractions, that sometimes just that little bit of pain medication will help her to relax enough for the body to be able to do what it's supposed to be doing. All right. Mechanisms of spontaneous vaginal delivery. So in order for a vaginal birth to occur, the infant must pass through the birth canal or the passageway. And these turns and movements are referred to as the cardinal movements of delivery. You're going to have to know these. All right. A, B, C, D, E, F. 6. There's 6 of them. Make some flashcards. I had to make myself some flashcards to go over these just so I can keep them in track, okay? Make flashcards, make a poster, whatever you need to do. You're going to need to know these 6 cardinal movements of delivery. You're going to need to know all about them. We've got engagement and descent, flexion, internal rotation, extension, external rotation, and expulsion. They go in this order. You need to know this order. Sometimes they will overlap, and sometimes they will occur spontaneously. But in general, this is the order. Okay? All right, so starting with engagement and descent, it's the initial movement of the fetal head into the pelvic inlet. We already talked about that. Flexion is the fetal attitude, presenting the smallest part of the fetal head to the dimensions of the maternal pelvis, so the fetal head is tucked head to chest. As the head descends during labor, the fetus often assumes a flexed position as the head encounters resistance from the muscles of the pelvic floor. Okay, then we've got internal rotation. This is when the fetal head rotates from a transverse position to an anterior position. So in early labor, the fetal head presents to the maternal pelvis in a transverse position because the pelvis is widest from side to side. During active labor, the fetal head typically rotates to the anterior position, which is most favorable for delivery. And if this rotation does not occur, the labor is prolonged because we've got the widest diameter of the fetal head presenting through to make a much tighter fit. If the fetal head rotates posterior instead of anterior, labor is going to be prolonged as the infant has to rotate further to an anterior position prior to birth. All right, then we have extension. Extension is when the fetus reaches the pubic arch and must extend the head, kind of like a turtle, to pass under the pubic arch and the symphysis pubis. Then we have external rotation. This is the birth of the head. With the birth of the head, the shoulders must then line up with the head. I'm going to show you some pictures, and I'm pretty sure we've got some videos posted on this also. And then we have expulsion, which is birth. It occurs after the delivery of both shoulders. Both shoulders have to be delivered. Here are your pictures for your cardinal movements of delivery. Again, please be sure that you understand this, when it happens, how it happens, understand the process instead of just memorizing it. watch the videos. If I don't have anything posted, I'll check as soon as I get done with this. If I don't have anything posted, I will post something, but I'm pretty positive I have some videos posted, so be sure you watch them. Then we've got stages of labor. Labor is categorized into 4 different stages. More flashcards to make. Your first stage of labor includes early, active, and transition phases. Latent, active, transition. Be sure you understand this. Second stage of labor is birth of the fetus. Third stage, delivery of the placenta. Fourth stage, recovery. Okay? 4 stages of labor. First stage includes 3 sections: latent, active, transition. Second stage is birth. Third stage is delivery of the placenta. And fourth stage is recovery. First stage of labor is dilatation and effacement. It begins with the onset of true labor contractions. It ends when the cervix is dilated to the full 10 centimeters. It generally lasts 8 to 20 hours for primips and 5 to 14 hours for multips. Be sure you remember what are primips, what are multips, and what's going on in this stage of labor. All right, it's subdivided into 3 phases. We've got our early or latent phase. Know the latent phase. Dilation is only 0 to 4 centimeters during this latent phase. Your contractions are about every 10 to 15 minutes. Could be closer, but about that time. And then as labor progresses, the contractions become stronger and closer together. Then we've got our active phase of labor. This is when we've got dilatation at 4 to 7 centimeters. Frequency of contractions is every 2 to 5 minutes. Duration is 50 to 60 seconds, and intensity is moderate to strong. Go back and look through the notes. What did we just say? Mild, moderate, strong. What is moderate going to feel like, and what is strong going to feel like? And we're going to have some increasing discomfort. Primips usually dilate approximately 1.2 centimeters per hour, and multips dilate about 1.5 centimeters per hour. This is very average numbering. Can range dramatically. Then we have our transition phase of labor. This is at the first stage of transition phase of the first stage of labor. Dilatation is 8 to 10 centimeters. The frequency of the contractions is 2 to 3 minutes for 60 to 90 seconds with a very strong intensity. Characterized by the most difficult part of labor, where the woman has a strong urge to push as the fetus descends. It is very important to keep the woman from pushing until the cervix is fully dilated. Sometimes they feel like they need to push even at 8, 9 centimeters dilatation. They'll tell you, I feel like I need to push. Do not let them push. Otherwise, it's going to cause a lot of swelling and edema to that little bit of cervix that's still hanging out right there in the birth canal. And also can cause some lacerations to the cervix, which can lead to hemorrhaging. Okay. Now we get to go to the second stage of labor. Remember, the first stage was until 10 centimeters dilated. Now we get to go to the second stage, which is birth. It's from 10 centimeters to birth. It's characterized by the maternal pushing. Starts at 10 centimeters and ends with the birth of the infant. The woman feels as if she has to have a bowel movement. Usually they'll state to you, I need to go to the bathroom. Can I get up and go to the bathroom? I've got to go. Number 2, really bad. Don't let them go. Okay. You say, oh yeah, okay, I think, we just checked and you weren't that far along, and they get up and go to the bathroom and they deliver a baby in the toilet. Don't let that happen. Okay. You always want to check their progress of labor first. You always check their cervix before you let them get out of bed to go to the bathroom. Usually it's just going to be a bedpan though. The average length of the second stage for primips is 1 to 2 hours, and multips a few pushes to an hour. And the fetus continues to descend and rotate down, and pushing is characterized by your steady, slow downward progression of the. All right, so we've got the third stage of labor here. That's delivery of the placenta. It begins after delivery of the baby and ends when with the delivery of the placenta. The duration is 5 to 30 minutes. And signs of placental separation would be a gush of blood, lengthening of the umbilical cord. The umbilical cord will get longer when the placenta is separated, because then it'll start being able to be delivered. And you'll have a globular shape to the fundus. All right, oxytocin is given to help keep the uterus firm and control maternal blood loss. The fourth stage of labor is recovery and begins immediately after delivery of the placenta. Lasts for 1 to 4 hours. And the woman is observed frequently for signs of hemorrhage and other complications. We're checking vital signs very frequently. We're doing fundal checks. Checking to make sure the uterus is clamping down and contracting nicely, that the fundus is very nice and firm. We're doing lochia checks, checking the amount of bleeding, vaginal bleeding that she's having. The woman's usually very tired and very hungry, and the body is going through tremendous changes after the labor and delivery process. Maternal responses to the stages of labor. The hard work of labor puts the demand on the woman's coping mechanisms. So responses vary with different stages of labor. Often in early labor, they're very talkative and excited. They're anxious. They're a little apprehensive. Then we get to the active labor and they're a little more introverted. They're more focused on what's going on, what's happening, what, their pain level is, how often the contractions are. And they use a lot of energy to focus on those contractions. Then during the transition phases, women have difficulty maintaining positive coping mechanisms. They feel out of control. They need a lot of support, encouragement, and positive reinforcement during this time frame. While they're pushing, we get the women feel a nice sense of relief. They're better coping skills because they're actually doing something, actively pushing, and they feel more in control of the situation. So if a woman's inadequately prepared for labor and loses control during labor, they usually cry, scream, thrash around in the bed. This response will slow labor progression due to the muscle tension. So remember I talked to you about that a little bit earlier, about the tension kind of counteracting what the body is trying to do. And tense muscles work against cervical dilatation and fetal descent. All right, be sure this is the wrong page numbers up here. It's table 6.5 on page 140 and 141. Okay, discusses more physiologic changes in labor. All right, the end. There's our baby. So I think now we've caught up. Next class we will go into, what are we doing? Nursing care during labor and delivery and labor complications, I think. Please send me any questions, email me any questions you might have so that I can present them to the whole class. Everybody can get answers to the questions. This is very difficult information. Be sure you make note cards on these stages of labor, the 4 Ps, the cardinal movements, the so many different things that we've discussed. So be sure that you understand the differences, make some compare and contrasting in the different stages, different sections, and ask me any questions you may have. All right, thanks.